Hello and welcome. This is your Brain on Drugs. This is the punk rock psychiatrist here, and I'm continuing today. And what we're gonna do today is finish off the rest of the adverse effects from the serotonergic medications. Okay, and then in the next episode, I will cover the selective serotonin reuptake inhibitors. So, previous to now, I wanted to cover some of the big adverse effects, some of the most important ones, and that have like a lot of surrounding details and dedicate whole episodes to those. So, we've done QT prolongation, we've done serotonin toxicity or syndrome. We've talked about the black box warning for suicidal thoughts, and then we've gone into the sexual side effects. And so those are some of the side effects of these medications that I think we think of most prominently. QT, not that often of an occurrence, pretty rare actually. Serotonin syndrome, also very rare. And then the suicidal ideations, that can not be that uncommon. So, and it's got the black box warning, and there's a lot of history around that. So if you haven't listened to that episode, I think you'll find that really interesting. And then the sexual side effects, that's something that happens with these medications around 75% of the time. And it's often what bothers patients the most. And so I wanted to have a whole long episode on that. Okay. And then today we're just going to go through all the other adverse effects. Okay, so let's go ahead and get started with that. So before I go into that, I just wanted to kind of do an overview of adverse effects with these medications. Okay, so I think I had mentioned previously that you often get the adverse effects before you get the positive effects. And so the adverse effects often appear in the 1 to 2 weeks after you've started taking them, sometimes even within days. And then they usually slowly go away. And the problem is that patients will often stop the medications in response to these. Maybe it was something unexpected that wasn't discussed with them, or something that was frightening to them. And that's why I think it's important to answer the questions. You can't go through all this. It's just so much. And so, I think it would be great if you wanted to share the podcast with the patients so that they could hear a long explanation that might answer their questions, and then they can come in and have the questions with you. So hopefully that's something that you would feel comfortable advising to your patients. And so, patients will often stop. And then what you'll need to do is, ask them why, and then you can address them. So we can't address everything up front, but, just kind of explain, yes, that's very common, that happens, but it often goes away. Unfortunately, the sexual side effects, which is often one of the most bothersome, it typically does not go away with time. We went into huge depth on how to treat that. So I did 2 full episodes on that. So please listen to those if you have questions about the sexual side effects. But often the best thing to do is just to be on a lower dose. And if a lower dose isn't going to work, then, there's a lot of other things we can do, but please refer to that episode. But the other adverse effects often go away. And so it's important to tell patients, unless this is unbearable, unless you're like really feeling like you're going to have to end up in the hospital, or it's just completely intolerable, give it some time, see if it gets better. And also, the positive effect, it takes longer before you're going to feel that. And so, you may want to quit because you're like, oh, I'm getting nothing but adverse effects. But if you get the positive effects, and maybe the adverse effects still stick around a little bit, but they're less, but you're getting like a lot of benefit from it, then you might decide, oh, you know what, this isn't that bad because the benefits outweighing the risk. But the problem is that the downside comes first, and so they don't get a chance to experience the upside. All right. So it's important to explain that to them. All right. And the other thing is, up to 3/4 of patients would have no adverse effects on low doses. Now, if you increase the dose to the higher doses, they're much more likely. But if, we can get them on the lower doses and those are effective, most patients are not going to have adverse effects at the lower doses. So that's why it's important to start low on these medications to see if those lower doses work. and not just assume that they're going to need a higher dose. First let's see if that works. And, they may get tolerant. We may need to raise it later. They may not get any effects at all, and then we'll need to raise it. But if we can have them on those lower doses, there's a, huge chance they're not going to have any adverse effects. All right. Only around 10 to 15% of patients are not going to tolerate even a small dose of a particular SSRI. And in those cases, we try different medications. We have a lot of medications to choose from. These are typically our first line medications, the SSRIs, or, the medications that affect serotonin. All these adverse effects I'm going through, they're serotonergic adverse effects. So they're effects you're going to see with MAOIs or TCAs or SNRIs and SSRIs. Okay. But, the SSRIs only affect serotonin for the most part. And so that's why we're talking about those now in the lead up to the SSRIs. Okay. So there are a few patients that won't tolerate even, small doses of these meds. And that's when we try a different med. Maybe we try bupropion or something else that doesn't affect serotonin. Maybe we try mirtazapine. We have other options. Okay. So, but these are generally the meds that we're going to reach for first. Okay. And over 50% of patients who respond poorly to one SSRI will respond favorably to another. So half will, half won't. And I know a lot of people, they like to give a patient 2 SSRIs before they move on to another med. And I think that's a good approach. I would not take that approach with every single patient. There are patients that I might decide, what, let's go with an SNRI. Let's go with NDRI. Let's go, with something else next. And so it's going to be based on, how they responded and what their clinical presentation is. But don't just give up on the SSRIs as a class if they didn't respond to one. And also, they may respond to one but get the adverse effects, and then they may also respond to a second one and not get those adverse effects. So all the SSRIs, I mean, when we talked about the TCAs, if you look at their chemical structure, they all have that tricyclic ring structure. They all look similar. Okay. And if you look at the SSRIs, they all have a completely different chemical structure. So although they have the same mechanism of action, they're very different molecules. And so in one brain or another brain, one might respond differently. You might get adverse effects with 2 and not one other one, or positive effects with 3 of them, but not 2. And we kind of, just because you respond to one doesn't mean you're going to respond to another, or have an adverse effect from one, you're going to have it with another. It's really hard to tell. And I mean, there's patients out there that have tried 2 or 3 that I would go with a 4th one. And, those are patients that maybe we've tried some of the other things too, and those didn't work out. All right. So let's go through the rest of our adverse effects associated with these serotonergic medications. So I'm going to break these down by systems. And so first, let's look at the central nervous system effects. So a big one is patients may have sedation or insomnia, which is kind of interesting. Why would you have one effect versus another one? And we don't know. Some patients get sedated with one SSRI and insomnia with another, or vice versa, and another patient's different. So I tell patients when they ask me what time to take a medication, I say, whenever you want. Doesn't matter. Generally, I would say they're more sedating. So I usually tell patients, go ahead and take it at night. And if that's not working out for you, move it to the morning. If you find that your sleep's worse, why don't you try take it in the morning? And another thing is, if patients are already on a couple other medications and they take all those meds in the morning, I might say, maybe you should go ahead and try taking this in the morning, because I don't want you to forget to take it. And so if you take all your meds at the same time, and maybe the other meds they're on, it's more appropriate to take them in the morning. Maybe they have an ADHD medication or something like that where they need to take it in the morning. And so just so that they don't forget, because these meds don't work that great if you don't take them every day. In fact, they don't work that well at all. It's more of a placebo, in my opinion. If you're saying it's working on a PRN, as needed basis, it's probably mostly placebo. And these meds are mostly placebo, unfortunately. But at the same time, the placebo effect's quite robust. So we can still get a pretty good effect if it's only the placebo that they're getting, because they wouldn't be taking a placebo otherwise, because they're not in a drug trial, right? So, and these meds are, for the most part, pretty safe. And that's why these are the ones that we use now. The MAOIs, we talked about those and how dangerous they can be, and the TCAs and all the risks associated with those. With the serotonergic medications, these SNRIs, the risk is just so much lower. And so, if they're just getting a placebo effect, and they're, and that's helping, and they're not having these potential dangerous adverse effects, then it's a win. They're doing better than they would be had they not come to see you to take the medication. All right. So sedation can happen, and often a switch to an SNRI, the SNRIs tend to be more activating. I would say fluoxetine Prozac is a little more activating. And so you might want to, if they're getting the sedation, try fluoxetine, try an SNRI, try an NDRI, Wellbutrin, bupropion, right? And the sedating effects tend to be worse with paroxetine, and that's because of the anticholinergic effects it has. And then fluvoxamine, those two tend to be more sedating, and those would be the ones that I would definitely be telling people to take at night. And then with insomnia, I said you could treat it with fluoxetine. You could switch someone to fluoxetine if they were having sedation. So you wouldn't want to give them fluoxetine necessarily at night, because it is more activating. Now, that's not to say that I haven't had a handful of patients that say that it works better when they take it at night. And that's why, I tell the patient, experiment with it. If you want to take it the middle of the day, beginning of the day, end of the day, kind of see how you're feeling. And if you're having something where you think that moving it to a different time might benefit you, go ahead and do that. And they often express a concern that, well, do I need to skip a day, or, can I just move it to the next time the next day? And that's perfectly fine, right? If you're on one of these medications at night and you want to switch it to morning, and that's just going to be like 8 hours after you took your last dose, that's perfectly fine, because you can take higher doses of these medications. We will increase the meds, and you moving it, to morning one time is not going to have any kind of dangerous effect, and vice versa. If you took it in the morning and wanted to switch it at night, I would go ahead and take it the next night versus that same night, just to kind of keep it on the once a day schedule. But if you did go ahead and take it that night, I wouldn't expect anything scary to happen with that. Okay. And if you do get the insomnia with these, you could switch back. You could switch to one of the more sedating, or try a different one. But you could also try adding something like trazodone, which has, and it's an antidepressant, but it's also very sedating, and a low dose of that might help, or mirtazapine or something like that. So you could add a med or switch to help with that insomnia adverse effect. All right. Headaches is something that can happen. Once again, doesn't tend to persist into the long term. Vivid dreams and nightmares. So serotonin can affect, people will say, they're getting weird dreams, but is it a problem? If it's scary and it's nightmares, maybe we want to change it and do something about it. But if it's just like, it's really realistic dreams, can you live with it? Is the benefit outweigh the risk? But that is something that can happen. So if they report that, it's something that you definitely will see. All right, so that's kind of rounding out the central nervous system effects. Moving on to GI effects. Now, this, I would say, so nausea, vomiting, diarrhea, but mostly the nausea, that is probably the number one thing that patients are going to notice from the get-go, right? They're the sexual side effects tend to not pop up right away. You tend to need a little bit higher doses and a few weeks before those start coming up. But the GI adverse effects can happen very soon, like first dose. These are the ones that happen the earliest, and they're actually the number one reason why patients stop taking the medications. And it's around 20% of patients get this. And Sertraline is generally the medication that is most likely of the SSRIs to cause this. And so you might want to not use sertraline as your first choice because this is such a common adverse effect, and it is such a big reason why people stop the medications, and they may not be able to verbalize to you exactly why they did stop the medication, and then you kind of miss the chance to use these medications. So I back when I first started practicing, Zoloft was my first choice, and I've moved over to escitalopram, Lexapro. That's generally my first choice. If I've got just a generic presentation in front of me and I don't have any reason to really pick one med over another, I like escitalopram because, you know, fluoxetine tends to be activating and can cause insomnia more likely. It also has a lot of drug interactions. Paroxetine has a lot of anticholinergic effects. Fluvoxamine's got the short half-life effects. Um, Sertraline's got the GI upset effect. Citalopram's got the QT prolongation risk effect, and that kind of leaves me with S-citalopram. And it doesn't have the drug-drug interactions. It doesn't. It's it's probably in the more tolerable category, and so I generally go for that one first, unless I have a reason to pick something else. And I might pick a med that's not an SSRI, but when I'm going to pick an SSRI in a patient who's never taken an SSRI, I usually go with escitalopram for for those reasons. And I would say sertraline is probably the number one medication. If you look at like what's the number one antidepressant that's out there, it's sertraline. And so I think that's what most people reach for, but I tend to go with the escitalopram because sertraline has a slightly higher risk of these GI adverse effects. Okay. But that's not to say this is a bad med or that that's a bad idea to choose it first. It's probably a very small difference. And I just like to increase my odds. And I feel like I do that when I pick escitalopram. Um, Giving the med with food may help these GI effects. And when I say sertraline is the biggest, culprit in this, they all do it, right? The other thing that I do, and a lot of people don't do this. This is something, one of my staff taught me when I was a resident. When you look at the starting doses of these medications, so let's take, for example, sertraline, it's 50, or Prozac is 20, or escitalopram is 10, or citalopram is 20, right? I half those. Whatever the starting dose is, or even like some of the other meds like venlafaxine 75, or um, I half it. I give them a 10 of the escitalopram and I say take half for a week and then take the 10. And the reason why I do that, it's the GI adverse effects. That's the reason. I don't think that taking that low of a dose to introduce them with makes that much difference with the other adverse effects that you might get from these medications. But for the GI effects, I'm sorry, I said nausea was the number one of these GI adverse effects. It's actually loose bowel movements. I misspoke there. And that's what happens. And it's embarrassing, right? So, you're taking this med, and then what happens is, you've got all this serotonin in your gut. Like that's why you're having these GI adverse effects in the first place. You have more serotonin receptors in your gut than anywhere else in your body. And that's the whole mind gut connection, right? Our mind and our gut when we were embryos used to be very close together, and they kind of pulled apart. And so we've got serotonin. Most of our serotonin is in our brain, our central nervous system, our spinal column as well, and in our gut. And it helps with the movement of food through our GI system, right? And when you give people these medications, especially in the beginning, it typically will increase that propulsion of food matter through your GI tract. And what happens is you'll have more bowel movements than you typically would. Okay. If you were having one a day, maybe you're having two or three now. And that may not be so bothersome, The main issue there is that it's difficult to hold it in, right? So you're going to go to the bathroom. I've taken these medications. Remember, I said I was going to tell you if I've taken these medications. I've taken them. I've taken fluoxetine. I've taken sertraline. Um, I think of the SSRIs, those are the ones that I have taken. And the fluoxetine was a long time ago. I don't remember having any adverse effects, but with sertraline, I do remember I got this like loose bowel movement thing. So not only are you having more bowel movements, but they're more liquidy and loose than they would be otherwise. And that did happen to me. And the other hard part about that is, if you need to have a bowel movement, typically you can hold it until you can get to the bathroom. When you take these meds, oftentimes you can't, and you leak out just a little bit, and then it gets in, it gets in your underwear, and then it smells and it's disgusting, and you need to change your pants, and who wants to go through that? Especially if it's happening all the time. And that's the number one reason why I give that half a dose for a week, because this effect tends to go away. I would say in 9 out of 10 patients that get it, if not more, within a month or two, they're not getting this anymore, or it's kind of settled down. They're still having more bowel movements. Their bowel movements are still looser, but they're not having accidents. It's not quite as severe as it was before. And some patients get this very severe, and some patients, like I said, most patients don't get it at all. And if you go into too much detail with the patients about this, you may convince them not to take it. But it's not super common that it will be the worst of those effects. But that's why I like to give the half dose. And the thing is, there's no real risk to doing that. You're starting them with the starting dose, and you're just giving the half for a week. And you're going to see them typically back in 4 to 6 weeks, and they're going to be on the starting dose for several weeks by the time they see you, and you'll have a good chance to judge what's happening. And it's more likely that they still will be on the med because you started at that really tiny dose. And so that's why I like to do that. And I do it with all my patients. I start with 25 Zoloft. I start with 10 of Prozac. I start with 5 of Lexapro. I do those half doses. All right. And that's the main reason, the main way that I combat this GI adverse effect. So it's mainly the loose bowel movements, but in even fewer patients, the vomiting, not that common. Nausea, probably the next most common after, loose bowel movements. And I don't call it diarrhea, because diarrhea is going to the bathroom like over 6 times a day. This is typically 2 to 3. It can be worse with some patients. It's not water, but it's loose. All right. So I spent a lot of time on that one because this is probably one of the most important adverse effects. And it's one of the most important ones to warn them about. Like, this could happen. That's why I'm going to start you on an extra low dose and give it time. It should get better with time. All right. And if it doesn't, we'll address that and change it. Okay. Now, you can get the opposite effect. You can get constipation. Paroxetine is the most common to get the constipation because it has anticholinergic effects. But I've seen constipation with all of these meds. I'm not exactly sure how that's happening. Maybe, you think the serotonin should be speeding up the track, but with these medications and with all mental health medications, you're dealing with a very complicated system in that we're dealing with the central nervous system. And sometimes you get the opposite effect that you would expect to get, with one patient or another. And so someone might get constipation instead of the loose bowel movements, even though they're on one of the meds that's not anticholinergic. Okay. And with paroxetine, in addition to the constipation, you can get all those other anticholinergic effects that if you want to hear about that, listen to the tricyclic episode. All right. And with the paroxetine, there is a CR, or controlled release formulation, that when I get into paroxetine later, I'm going to talk more about that, but that might help a little bit with the constipation issue. All right. So let's keep going. Sweating is another thing that can happen. I've seen this a handful of times. I think with most of the adverse effects, I'm going to consider either lowering the dose or switching them to another one. I don't like the prescribing cascade of, wait, I gave you an adverse effect with this med, so I'm going to add a med to combat it. And then you're getting an adverse effect from that med, and then I'm giving you a med to combat that. And now you're on 3 meds, even though only one of them is the one that we wanted to work, right? So I don't love the idea of combating these side effects with another med, but that is something that you're going to have to consider, right? Because maybe this is the only med that worked. You tried a different one, they didn't get as, they're like, I really liked the first one the best, and I hated that effect. I hated that I was constipated, and we're just going to have to take Miralax to help with it. Or, I don't like the loose bowel movement. Sometimes I might have to take some Imodium to combat it or something if it's really bad. Or, the sweating, you can add an alpha blocker like Terazosin or something like that could help with the sweating. So if they get the sweating with all of these meds, or if they only get it with the med that actually helped them, you may have to consider adding a med. But like I said, with any of these adverse effects, my first thought is, can we take a lower dose? My second thought is, can we switch to something else? And then my thought is, all right, we need this med. It's really helping us, and it's the only one that's working. Is there something we can add to combat it? So the prescribing cascade is kind of the last ditch effort, but it's one you're going to go to often because that is often the situation. All right. So there is an increased risk of the sweating. So I like to talk, we're talking about which meds are more likely to cause these with each. So the short acting agents, and I'm not entirely sure why something being short acting would lead to this adverse effect, but that just seems to be the way it is. And paroxetine, fluvoxamine, and venlafaxine is an SNRI, so it's also serotonergic. Those three, and also venlafaxine, the norepinephrine piece is also helping with the sweating there. So those shorter acting ones, more likely to cause it. All right. Next adverse effect, bruxism. So that's teeth grinding. And if we want to combat that, buspirone would be something you could try. If switching or, lowering the dose didn't work, buspirone is something we could try for that. Next, weight gain. All right. When I had first learned about these medications and I was in residency, I was being told, they're weight neutral. Patients may say they're gaining weight, but, it's probably their diet. It's not the med. And that's really not the case. A third of patients will gain weight on these medications. Most, it's not very much. It's not enough to be concerned about. One potential explanation for this is that, of course, serotonin, when you look at serotonin, there are serotonin receptors that affect appetite. And so you could completely get this just because of the serotonin effect that the med is having on the body with your appetite, your fullness, or that sort of thing. But think about these medications. Now, we call them antidepressants. And, they get a lot of bad press for not doing a very good job on depression, right? Like with mild depression, we typically recommend not to even try medication because they don't work better than placebo. With moderate depression, there's a slight benefit, not really statistically significant, but with severe depression, those are the patients that really benefit from these. But that's when we're just talking about depression. But what about when we're talking about anxiety? Okay, I'm going to have a whole series of anxiety lectures, and we'll talk about what meds, I mentioned, all the different FDA approvals these meds have, and some of them are anxiety conditions. They actually do work a lot better with anxiety symptoms than they do depression symptoms. So if you're a patient or a provider or whatever, and you've kind of heard this, oh, these meds don't really work. Well, they work pretty well for a handful. I'd say a third of patients, they work pretty well for depression, and they tend to work the best in patients with the more severe cases and the ones that are less caused by life circumstances. But for anxiety, they actually do work quite a bit better than for you don't have to worry, the mild, moderate, severe. They with the depression, it's more the severe, but with anxiety, they do tend to work a bit better. All right. So I've had this explained to me before, and I like this idea. I'm rounding back. We're still on weight gain. Okay, we're still talking about weight gain. So say you've got like an agitated, anxious patient, and often, right, anxiety and depression go hand in hand, and sometimes one causes the other. So you're really anxious, therefore, it's really uncomfortable and it's making your life, miserable, and so you become depressed. Or you're depressed and, it's unpleasant being depressed and it puts you in these situations you don't want to be in, and that makes you anxious. So sometimes one can cause the other. I think more than likely they kind of feed off of each other. You have a little bit of depression causing the anxiety, a little bit of anxiety causes depression, and we try to think, what's the root here? Is this a mostly anxious patient that the depression is caused more from the anxiety? Is this a more depressed patient where it's the anxiety is coming more from the depression? And if you've got more of an anxious patient, then these meds are going to be a lot better for you. And then they could help with the depression because they're helping with the anxiety. All right. And regarding the weight gain situation, if you are an anxious, agitated patient, you're like shaking, you've got all this psychomotor agitation, you've got kind of a nervous gut because you're like, having panic attacks and things like that. So maybe you just don't feel like eating as much. And now the med is on board and we're helping with that symptom. Now you're not depressed. You don't feel as nervous. You're not moving around as much. You're not as agitated. You're not as psychomotor, mo- mobile, right? You're not moving around as much, kicking your leg, tapping your finger. You're sleeping more, right? So you're in a more rested state, and maybe you're calm enough to eat a little bit more. And so some of that weight gain could be a direct cause of that increase in serotonin, but it also could just be that this was an anxious patient that's not as anxious. And maybe they were a primarily depressed patient, but they had some anxiety as well. And the med maybe helped with that anxiety. So that's where you may be getting the weight gain from. It could be control of the anxiety, so that you're wanting to eat more. And also, if you're depressed and sometimes with depression you eat more, and sometimes you overeat, and some you don't eat enough. And so it could be that you've returned to a normal diet, which is eating more than you were eating, and that could be why you gained the weight. Maybe you were kind of pathologically, thin. You maybe not, unhealthy weight, but thinner than your baseline because of the symptoms you're having, whether they were the depressive symptoms that was causing you not to eat, or they were anxious symptoms, right? In depression, you can get psychomotor agitation or psychomotor retardation, right? So you could be slowed up or sped down. So control of those depression or anxiety symptoms could lead to a situation where the patient is just not moving as much and is eating more. And that may be where the weight gain is coming from. So if they want to come off the medication, you get these patients like, I didn't want to gain this weight. I don't, this is unpleasant for me. And it's like, well, I think your weight gain, the weight that you're at now is more of a natural weight for you when you're at a healthy mental state. And if you're not on this med, you're going to feel anxious and depressed because that's how it was before. Is that really a state that we want to get to? Probably not. Okay. Now, could it be that this medication just the serotonergic effect is what caused the weight gain? Maybe. And then maybe we use something like bupropion, which is weight neutral or even weight loss, and that could help. So you go with something, or maybe the med that we used was a weight gainer like a mirtazapine, and so we go with something that's less of a weight gainer, right? So we could consider that. But we could also consider, hey, maybe it's just that you're feeling good. And now because you're feeling good, you're eating normally, you're living normally, and you've gained the weight. And so the way to attack your weight is not necessarily to get you off this medication that's made you well. It's let's look at your diet and exercise. Let's look at your lifestyle stuff. Okay. Um, so generally, if somebody has weight gain on these medications, it's often because they're doing better. And so taking them off is not really a good idea. And the other thing is you might want to judge, is you being 20 pounds overweight a worse situation than the way you felt before when you were depressed or anxious? And so some with a lot of these adverse effects, sometimes we have to do a cost benefit analysis. Like, I got these bad things that happen to me that I don't want. when I took the med, but I also got this benefit. And it's like, which is, is the benefit worth the risk? And oftentimes patients think it is, and then they end up changing their minds and they get off the meds. And then they find out maybe that it was worth it being on the meds, or maybe they find out it wasn't. I don't want people to take these medications and get side effects and they're not having any benefit. So weight gain is something that's going to come up a lot in about a third of patients. All right. And let's talk about which meds. All right. So tricyclics, and it's that anticholinergic effect with the tricyclics is a big reason. Okay. And then, histamine blocking. So you get a lot of histamine blocking stuff going on with the tricyclics. I'm going to have a whole presentation on weight, and we're going to go into all psych meds and all meds in general that can cause or reverse weight issues. But so just briefly now, tricyclics, they have the histamine blocking and the anticholinergic effects. So they tend to be the worst of these serotonergic medications for weight gain. And that's more of a med effect there than it would be just you benefited from taking the med. And then paroxetine, because it's got the anticholinergic side effects. And then next, sertraline, fluoxetine are kind of would be after that, and then the others. So once again, another reason why I like to use escitalopram, because it's a little bit less likely to cause this weight gain of this class of medications. All right. So next adverse effect, decreased bone mineral density. This is not something that I saw a lot because I didn't treat a lot of older patients, but in the elderly, they could get 4% less bone mineral density. And that might be an issue. If you've got a patient with osteoporosis and you're making it worse, that could be a problem. All right. And so they might need to take a medication like one of the like alendronates or those type of medications that help with that. All right. We got a few more adverse effects. And this is another one. This is another big one that comes up. Bleeding and anemia. And where you're going to see this is not so much in patients. Like, honestly, I've never seen a patient have bleeding or anemia caused by one of these medications. I think I saw anemia on duloxetine once. But this is not something I see very often. But where you're going to see it is whenever they're on more than one medication, and say they're on like ibuprofen, right? Which could also increase your bleeding risk. And then you're going to see one of those warnings that pops up. Oh, drug-drug interaction, it's a compounding effect. We've got two meds that could cause bleeding here. That's when you're going to notice it. It's not that common that it happens. And so many of you're aware of it because you've seen this warning pop up, but you're probably thinking, why does this even happen? Like, what's the deal here? All right. So all serotonergic medications have this potential, and there's actually serotonin signals that signal platelet aggregation. Okay. There's actually serotonin involved in the clotting cascade, which is interesting, right? And the bleeding can occur due to it occurs due to the serotonin depletion. And I tried to work this out to figure out how it works. I guess the serotonin reuptake inhibitors somehow deplete serotonin from this platelet aggregation system, maybe because it's being used elsewhere in the body. I could not really find a clear picture on there. All I know is that serotonin signals platelet aggregation, and that the SRIs deplete serotonin in the platelets. And then you get less of platelet aggregation, which can lead to bleeding. All right. And I don't know if that's an effect directly on the platelets by the meds, or if it's like a downstream indirect effect where you're having the effect somewhere else in the body and that's causing a depletion in serotonin in that area. I was unable to, I don't know if that's known. I could not find that information, but that's why it happens. And so when do I care about this, right? So if somebody's got a defect in their platelet number or function, or they have, bleeding disorder, or they're on chronic NSAID treatment, it's something to look out for. It would not be a reason that I would not try the medication on them. Maybe it's a reason to order a CBC on a patient like that. Maybe If they're noticing, the first thing they're going to notice is like more bruising. Um, and so it's something to have in mind. If a patient is saying that they're having increased bruising, maybe you want to check a CBC and think that maybe it's because of this med I gave them, right? All right. Next adverse effect. This is another big one. This is a huge one. Emotional dulling. All right. And the most common way that I hear patients present with this symptom is that they say they feel like a zombie. All right. You probably, those of you that are prescribed these medications, you probably heard this. The patient says, I feel like a zombie when I take these medications. And they typically don't like feeling like a zombie. They just, some of them notice it and some don't. Some, it's a good thing. Some of them, it's like, I felt too much. I had a labile mood. I was upset all the time. I was angry. I was sad. And now I don't feel that way anymore. And maybe the med's not helping with their anxiety or their depression, but it's causing this emotional dulling. And it's just a relief to not have these like extremes of emotions. Other people hate it. They're like, I'd rather feel crazy, to use that, term loosely, but I'd rather feel like I'm kind of, emotionally labile and all over the place than not feel anything at all. And so it's going to depend on the patient whether this is something that they like or don't like. And often I find that some patients, they like it at first because it's like, oh my gosh, a break from all that emotional ability I had. But, after a while, it's like, I kind of like to feel something. And um, a way that I often hear patients that this become an issue, if they don't notice themselves, it's their partners or their loved ones in their life. It's like, my wife complains that like I don't, so, like her mom died and I didn't react. I was like, okay, that's all okay, whatever. It's like, and when she asked me like how, like, can't you be more supportive? Like, aren't you upset about this? And the patient be like, I feel like maybe I should have been, but I just wasn't. It just didn't bother me. And so, and that may then point out to them, oh my gosh, this is actually an issue. Or maybe, it may threaten the relationship. And it's like, my partner is like, we're losing touch with each other because my partner is bothered that like I don't have hardly any emotional response. And so those are some of the ways I don't hear. This is something I don't hear talked about in like podcasts or educational material, but it's something that a large number of patients experience. And so it's something that I pay a lot of attention to because this is another big reason why patients don't want to take the meds anymore. They don't want to feel emotionally, they don't want to feel like a zombie anymore. All right. Maybe it was okay for a while, but they've had enough of it. And maybe if we lower the dose, and here's a situation, maybe they're on like the starting dose, maybe like a 50 milligrams of sertraline type of dose. And you think, well, why would I lower it to 25? That's like a nothing dose. Well, maybe, they're getting this emotional dulling, which is kind of an overcompensation for combating their anxiety. And then you lower the dose and they have a little bit more emotional ability, but more control. And that tiny dose, it may be doing something for them. And they may be getting just a little bit more control. Maybe it's not helping with like their anxiety disorder or their depressive disorder, but if it's helping with some of their mood lability, that could be a good thing for them, as long as it's not extreme. All right. So that's one to look out for. And it's one that I would not ignore. Like this is something that I really don't like about the way people practice medicine. They'll think, okay, well, I cured the problem with this patient. They're not depressed anymore. They're not anxious. The thing that I saw that I think was the problem with them, I no longer see this as a problem. And now this patient is complaining about these adverse effects and they kind of dismiss them like, big deal. You were like going to kill yourself before and now you feel like a zombie. Who cares? Right. And they may not say that directly to the patient. They may give that impression to the patient, but I hear people talking like this, or I'll have patients come to me and they'll say, this happened. It's been going on for months. And I'm like, well, why didn't you address it sooner? And they say, well, I said something, but they just kind of dismissed my concerns. And, some of them will just stop taking it on their own and not tell you. And some will just, keep taking it and feeling this way. And They're not, it's not the way they want to feel. Now, in some cases, it might be worth the benefit, but like, it's not up to me. It's not up to me to decide that. I don't decide, that just, I'm not going to project myself onto the patient, right? Not that I won't on accident, because we all do it. It's hard not to, but that's why you want to be, aware of that. Don't project how you would feel if you had this response. Like, how do they feel? What is, if this is something that's really concerning them, we need to do something about it. Maybe we have a med switch. Maybe we switch to a different class of medication. Maybe if they take an SNRI or an NDRI, this isn't going to happen. Okay. Don't just be like, oh, we found a med that fixed the symptom, even though it broke three other things. And I don't want to, I don't want to mess with the system because we fixed the thing that I was after. No, I mean, and what, this patient just has to live like this the rest of their life? That's ridiculous. If, I mean, if they want to do that, that's fine. If they're like, doc, I don't want to take a chance that I feel the way I did before. I'm okay with living with this. I'm not going to try and talk them out of it and say, do you really want to live like this? I think we can do better. Sometimes I'll push a patient a little bit, and be like, I think we could probably improve this if you want to go down that road. And if you don't right now, that's completely fine. But I just want you to know that if this becomes a problem for you at some point in the future and you decide, you know what, I think I'd like to try something else because this is kind of a problem, that we have options for that. You don't just have to go out there and stop the med on your own and never see me again, right? Come back. Let's, discuss it. Now it's an issue for you. And I just want to let you know that I don't know that I can fix it, but I know that we have options that we haven't tried yet that could do that. All right. And so I plant that seed. I'm not trying to push the patient one direction or another. I want them to be the most satisfied that they can be. If they're satisfied, I'm satisfied. Okay. Unless they're, psychotic and not thinking clearly, then of course we have to step in certain situations. But for the most part, I want them to be comfortable with their own treatment. And so if this is an issue for them, and I can understand how it would be, we need to address that. And there are ways to do that: changing meds, lowering doses, etc. Right? And maybe adding something as well. Right? So I want to spend, a good amount of time on the emotional dulling, because I think that's something that I just don't hear addressed. That's not something that's in the textbooks. It's not something that's talked about, but it's a really common adverse effect. And it's something that really can really impact someone's life. They could lose a relationship over something like this, and that could be completely devastating. And then all the good that we did was undone, right? All right. Next, manic switch. All right. So patients that have a bipolar spectrum disorder, and this is the thing, most patients with bipolar spectrum disorder, what do they present with? They present with a depression. That's why it's really important to rule out bipolar disorder, because we want to put those patients on mood stabilizers. We don't want to put them on SSRIs or antidepressants. Almost never do I want to do that. We'll go into a lot more detail on this when we get to the mood stabilizers, but I think it's important to talk about it now, because if a patient has a bipolar spectrum disorder, these meds can cause a manic switch. Now, I think some people in the past have thought that you can't ever do this, it'll always cause a manic switch. And then there's other people that say that this doesn't happen, it's not a thing. And, I think like anything, it's somewhere in the middle. It's something that is not unlikely to happen. It's something that, if they do have a bipolar spectrum disorder, is pretty common to happen. And they may not have a classic case of bipolar, that they just may be a little more agitated when they take the med. Maybe they don't have what you would consider, or the DSM-5 would consider, a manic episode or a hypomanic episode, but they've got a little more irritation, a little more anxiety, a little more, agitated state. And that may be because they have some sort of bipolar issues going on there. And so it's important to dig into that and then get them on the appropriate med, which is not a serotonergic medication. All right. And so, like I said, if they've got a family history of bipolar disorder, then even if they come in with depression, it's very likely that, maybe they haven't had an episode of mania or hypomania, or maybe they don't recognize that they had it. But if they've got that family history and they've got kind of a weird response to these medications, I would be thinking about bipolar disorder, and then I would be looking at maybe lithium or lamotrigine, not so much valproic acid anymore, but even maybe a carbamazepine or oxcarbazepine. Like, those are all, but even the ones that are like not the best, they're better than these serotonin medications if that's what's going on. So that another thing is, maybe they hadn't had one of those episodes before, or it wasn't recognized, and now that we gave them this med, we've kind of, it's presented itself. Oh, okay, wow, maybe they did, maybe this was not depression, maybe it was bipolar spectrum disorder. So that's something that these meds can unleash, and it's something that you should be aware of. And rather than just, thinking, oh, this is anxiety or insomnia that's, caused as an adverse effect of these medications, it's actually, we're a manic switch. And so that's where things get complicated, right? That's where like experience comes in, because the adverse effects that they have from these medications could look like a bipolar spectrum disorder, or it could be but it's actually depression, but we're just causing it like an adverse effect, or it could be a manic switch. So don't, I think a lot of people maybe don't have that in their mind. Always have bipolar spectrum disorder in your mind when you're treating a depressed patient, right? And I'm going to go into a lot more detail on this when we actually get to those, but it's very important to bring it up now, because a lot of people are okay with, it's hard to treat depression with a bipolar spectrum disorder. I'm going to talk about how to do it, and I'm going to say that the antidepressants are like my last of the last of the last line. In fact, I've never done it. Like, I would give somebody a stimulant before that. I'd give them, the mood stabilizers, and antipsychotic. Like, they're, I mean, not in that order, but these antidepressants, I just do not like the idea of using these in bipolar spectrum disorder. All right, so that's manic switch, and then EPS. So you can get extrapyramidal symptoms, usually caused by dopamine blockade, but not unheard of to happen with these medications. Now, the last one I'm going to go into is a little more detail, because I think, it's not very common, but there's more detail around it, and it's potentially dangerous. And maybe if there was more information on this last thing, and it's SIADH, syndrome of inappropriate antidiuretic hormone. So if I had a lot more information on this, I would dedicate an entire episode to this, but I just got 2 slides. So this one is another one that could almost get its own episode, but I'm going to cover it here with the rest of the adverse effects. So, syndrome of inappropriate antidiuretic hormone. What is this, right? So, what's antidiuretic hormone? Those of you that have been to medical training, remember what this is. ADH is released from your hypothalamus, right? It's one of those hormones that you have up there in your hypothalamus, and its effect is, it has its effect on the distal tubules in your kidneys, and it increases the absorption of water, right? That makes sense, right? What's happened is, typically the ions in your blood are too concentrated, and usually we're talking about sodium, right? So sodium is becoming too concentrated in your blood. We need to dilute it, and so antidiuretic hormone it's triggered by this, and then it's released, and we absorb more of our water. Instead of the water going into our urine, we concentrate our urine and pull that water back into our blood in our distal renal tubules, and it dilutes our blood, and then our sodium levels go back to normal. And this is something that we all do. It's a normal physiological state. It's how we keep the ions in our blood in homeostasis, right? It's one of many ways, we'll say, okay? So that's what ADH is. And normal levels of sodium, because we're mainly talking about sodium here, are 135 to 145. That's your lab values of your blood sodium levels. And hyponatremia is would be levels lower than that. And so when we're talking about syndrome of inappropriate antidiuretic hormones, so ADH causes dilution of our blood when we want it, but inappropriate syndrome of inappropriate antidiuretic hormones. So now we're releasing, or we're having an antidiuretic hormone effect that is overboard, right? And that's going to dilute our blood too much, which means that the concentration of our sodium is going to be too low. All right. And so you may see one of the adverse effects of these medications is hyponatremia, low sodium, or you may see it as SIADH. Those are kind of one and the same thing. The hyponatremia is caused by the SIADH. All right. And, hyponatremia would be levels below 135. But typically, we don't get really that much concern until they get below 130. And then we get really concerned when they go below 125. So mild hyponatremia would be below 130. If you're in the 130 to 135 range, we're not really that concerned. All right. But once we go below 130, you start to get mild symptoms: nausea, you feel tired, a headache. We're not really getting dangerous symptoms at this point, but this is a warning sign that we need to react and do something and get the sodium levels corrected. All right. Moderate symptoms start showing up when we get below 125. That will lead to neurological impairments. So that's not good. You get balance issues, a person's gait, which is, how they walk, they look unstable. That becomes affected. They may be falling down. So they start to get discoordinated, all right, when their sodium levels go below 125. Now, when they go below 120, that's severe. This can lead to seizures, coma, respiratory arrest. That's where you're not getting the signal to breathe, and death, right? We're really, really super dangerous at that point. But, typically what's going to happen is the patient's going to come in, a little bit nauseous, headache, feeling a little bit out of it, maybe balance is a little off, and they're going to get their Kim panel run, and this is going to be picked up. I mean, this is something that's, if they go for medical treatment, probably not going to get missed. They go to emergency room, pretty much everyone's getting, like, this is a blood test almost everyone's going to be getting, and then you're going to see it, and then they may get admitted to the hospital for treatment, right? And I'm not going to go through treatment because that's an internal medicine issue and it's not psychiatry, and it doesn't really have anything to do with these medications, but these medications can cause it, right? And then in addition to that, you can get pseudo hyponatremia. So that's where it looks like you have low sodium, but you actually don't. Pseudo means false, right? And so this is like the blood test comes back as your low sodium, but you actually have normal sodium. Something has screwed up the test's ability to measure your sodium. And that can happen with a few different conditions. Most commonly, it's having high amounts of something in your blood that's throwing off our ability to measure sodium. So that could be like, we have a lot of triglycerides, so severe hypertriglyceridemia, DKA, so that's diabetic ketoacidosis. So we've got a very acidic blood situation there. HHS, hyperosmolar hyperglycemia. So like with DKA and HHS, we've got like high levels, 5, 6, 700, level of glucose in our blood, when it should really be below like 200 in the safe zone. And then hyperalbuminuria, so that's like too much protein in the blood. So those are some things that can throw off the test. And so if you get low sodium numbers, I mean, the way to fix it is you give them, first, I'll go in a little bit about the treatment. The first thing you would do is give them water restriction, and then you might give them a more concentrated saline solution. But you have to be careful not to overdo that, because I can't remember the exact name of it. Internal medicine will laugh at me. It's a pontine something, so the pons of your brainstem can get affected if you overcorrect the sodium, and it gets hyperosmolar in there, and edema and stuff, and messes up your pons, which controls your whole body system. So Pontine cerebral. I can't remember. But anyway, that's what happens if you overdo the correction of the sodium. You don't want to correct it too quickly. That's why we do the water restriction first. But you want to make sure that they actually do have hyponatremia. So if they've got one of these other issues, and hopefully you measured their glucose and their protein and their triglycerides as well, so that you would be able to detect this. That would be an important thing to do. If someone has low sodium, you want to rule out something that would suggest that they actually don't. All right. So obviously we know that the meds that we're talking about now cause this, but what are all the causes? So cancer is one. So 25% of cases of this are caused by cancer. Lots of different types. Small cell lung cancer is the most likely of all the cancers, but many can. And essentially the tumor secretes the ADH, right? So you're just getting extra ADH coming from this tumor, right? CNS disorders, so anything that like messes with the brain, because that's where ADH is supposed to be secreted from. If it's not being secreted by a lung tumor or something like that, it's supposed to be secreted in your brain, in your hypothalamus. And so if you've got like a subarachnoid hemorrhage, or you had pituitary surgery, because that's where hypothalamus is, and if you have a brain tumor or an infection in your central nervous system, or a stroke or head trauma, so anything that's like interfered with your CNS, it could disrupt your hypothalamus's ability to appropriately, it may overdo it or it may underdo it, right? And then there's a whole host of other things that could cause this, from pulmonary to hereditary to sarcoidosis, lots of other stuff as well. But I want to focus on drug-induced SIADH. But I just wanted to make sure that just because this is happening, it's not necessarily because it's the medication they're taking. There are other things that cause SIADH. That's why we went through those. 20% of cases are drug-induced. So tumor is actually, a cancer is actually the most common cause of SIADH, and drug-induced would be the next most common. They're pretty close. To which one, they both do it. About 20 to 25% of cases are caused by one of those two. And so there's lots of meds that actually can do this. The SSRIs are the most common, and that's why we're talking about it. 33% of drug-induced, so about a third of drug-induced SIADH is due to SSRIs. All right. But let's go through all of the meds. So, and there's different mechanisms, right? So some meds stimulate ADH release. So they actually cause your hypothalamus to release more ADH. These are medications like opiates, vincristine, which is a med used for cancer, platinum-based antineoplastics. These are chemotherapy. So, cancer can cause it, but also the meds we use to treat the cancer can cause it. And then MDMA, so ecstasy, can also stimulate ADH release. And I think, if anyone knows about that, these people, they drink all this water, and the MDMA is actually not lethal to you at all, but what it can cause is this issue, and then people drink a whole bunch of extra water, and then they get hyponatremia, and then that's what they die from, right? It's not the actual drug itself. It's typically because they've become hyponatremia. So that's stimulation of ADH release. And then there are meds that enhance ADH effect. So they basically take the ADH that you have out there, they make it work a little bit better. So NSAIDs can do that. None of these are like super common, right? Because people take NSAIDs all the time. This is pretty rare that would be a cause, but it is possible. And then there are ADH analogs. So these are meds that we actually give. So, and you're not really having SIADH, in my opinion, here, because you're basically taking an ADH, a med that works like that. So desmopressin, oxytocin, those act like ADH. They have the same effect on your distal renal tubules as ADH does. And in fact, when we give desmopressin, we're doing it because we want to have that effect, right? It's that we're having, often in that situation, we're having a deficit of ADH, and we're taking the desmopressin to replace it. So that would not be a common cause of causing the opposite problem, because it's usually what we're using to fix the the opposite problem of SIADH. And then lastly, we have the vasopressin receptor 2 activators. So that's what desmopressin actually and ADH do. They agonize this vasopressin receptor 2. Okay, and so there are other meds that can do that, right? Other than ADH, there are other meds that can do that. Or ADH isn't a med, but there are meds that can do that. And this is where SSRIs come in. So SSRIs, carbamazepine, oxcarbazepine, first generation antipsychotics, haloperidol is probably the most common, and cyclophosphamide, which is, of those meds, the only one that's not a psych drug. Um, I think it's for a chemotherapy medication, but I could be, I'm not 100%. But yeah, that's where SSRIs come in, and that's why I wanted to bring up SIADH, because hyponatremia, it's something you'll see. It's probably more likely in the elderly. I've personally never seen a case of SSRI induced SIADH, but my population is a very young, probably 20 to 40 on average, healthy, military fit population. And this is a lot more likely to happen in people that are more fragile, more frail individuals, older individuals, sicker individuals. Those are the people that you're more likely to see this in. And that just wasn't my patient population. But, you see this hyponatremia as a risk for SSRIs, and you may be wondering how. Well, it's because it acts on the vasopressin receptor 2, and it causes this basically ADH effect, and it increases the reuptake of water from the tubules into the blood, and that dilutes the sodium, and then you get the low sodium. And so, that would probably be. I'm one to not like to do a lot of blood tests, especially in like healthy patients that I'm just treating depression or something like that. I don't see a huge role for blood tests. I think a lot of people, they want to test a ton of stuff. And I'm going to have a whole episode on like blood tests. Maybe ruling out anemia or something like that might be worthwhile. But this is one, you might want to check a chem panel if you've got suspicion for hyponatremia, especially if you've got a patient that's a little bit higher risk of getting it, which, like, as I said, would be your older patient, your more frail patient. And in these patients, they're getting a lot of blood tests because they've got other medical problems. And so if you're seeing that sodium creep down, and remember, they're not going to start to notice it typically until it goes below 130. But if you were seeing them like around the 140 mark over and over and over again, and then you've started this SSRI on them, and now they're sitting like 131, that's a pretty big change. Now, not enough for it to cause a problem yet, but it could be that this is what's going on, and maybe it could get worse. Maybe if you increase the dose, it could be a problem. And so that's something that I would certainly be looking at. All right. Well, we had a great episode today. We covered a lot of stuff. We hit basically the major, other than sexual side effects, which I went over before. The other categories were a little bit less common, but we went through like all of the adverse effects. Like if you look at the package insert and you're like wondering like, what does all this mean? How common is it? Why does it happen? What can I do about it? Hopefully those questions were answered today. That's my hope. Hopefully I got to all those questions, and now you're like, okay, now I get all the adverse effects from these medications. And there's a lot. There's actually quite a lot. We think of these serotonergic medications as like super safe, that it's difficult if you take them in overdose for the patient to die. And most of these adverse effects, the hyponatremia, that's a QT prolongation. Those are some like dangerous ones, but they're super, like, they're really rare. They just don't happen that often. Most of the adverse effects are just ones that make the patient uncomfortable. And, I said it that way on purpose because that's the way people think about it. Oh, it just, makes them uncomfortable. It just affects their sleep or, their sexual functioning, or makes them a little nauseous, or they have a couple more bowel movements, nothing that's going to kill them. Right. But I don't want you to think about it that way. I want you to think about it, is this bothering the patient if it's happening? And if so, how much? And if it's significant, would they do they feel like in this medication, if we've just started the medication, then let's give it some time to see what happens. But if we've been on it for a while and it's doing something that we want it to do, because if it's not doing something we want it to do, we've already stopped it for that reason, right? But if they've been on it for a while and it's doing what we want it to do, but they're getting some of this other stuff and it's just not going away. Maybe it got a little better, but it's kind of stabilized and it's getting a little annoying. And the patient's thinking, do I want to deal with this for the rest of my life? You've got to address it. You have to address it, right? And there are things you can do. And sometimes it might just be reassurance of, hey, maybe the patient was worried that it was like killing them or something. And you just say, no, this is why it's happening. This is the mechanism. This is why we would be concerned. I'm not concerned for your safety, but if this is something that is like bothering you and makes you not want to take the med or making you think it's not worth it, let's do something about it. And if they say, yes, let's do something about it, then do something about it. If they're like, okay, well, I feel better. I was just worried that like maybe I was dying and you've reassured me that I'm not. And so I'm fine with it, right? So the important thing is to address it, to talk about it with the patient, to find out how they feel about it, find out if they want to address it, and then go over their options, and then pick which one that you guys come together with that works best for the patient. And this is huge, right? This is such a huge thing because I think we think of these medications as like they're super common. We use them all the time and they have a lot of adverse effects. They just do. Now, remember at the beginning, I said 3/4 of the patients aren't going to have any of this if they're on a low dose. But if they need a higher dose, then it's super common like that something could happen and they may not like it. So don't just write it off. Don't just say, this isn't lethal, whatever. Like, don't dismiss the patient's concerns. Address them. Make them feel they need to feel heard, and you need to empathize. And you should feel that. Like, if you felt that way, wouldn't that bother you? And then someone's basically telling you it's not a big deal. All right. So, I hope you liked it. We're gonna go over SSRIs next time. And I just want to thank you for joining me. Follow, like, give me feedback, and I will see you next time. What's wrong with